Well, let's talk about the stuff that you'd object to as being too Goliathy a way of helping the working poor. I mean, so one, for example, there was a attempt to create a public health insurance plan in New York at one time, the New York Health Act, and I'm guessing that you would oppose that as being too Goliathy, or no?
Yeah, my worry about healthcare is I see what's happening right now, particularly in New York City, but throughout the country. Most of the best doctors in New York City, and I speak about the country, but I always focus on New York because I know it best. So what I see happening in New York City is many of the best doctors are simply not taking insurance anymore. They're just not taking it. Like, nope, pay by cash. That's all you're going to get, nothing else. And if you have, we'll tell you, we'll give you a bill. You can hope your insurance reimburses, but that's it. So what's wound up happening is you're having two tiers of healthcare right now. You have the wealthy who go to people who don't take insurance, and the poor who go to whoever will take insurance. That's what's happening now. And there's a massive difference in the service level you're going to get. And you've probably seen it I don't know if you have that world where, do you live, where do you live, by the way? I'm sorry.
Well, it's a little complicated. I'm about to move, but right this second, Michigan.
Okay, so you may not know New York City specifically, but if you do, that's how it's working right now. So if you go to a doctor's office now that takes insurance, generally speaking, your appointment's at 2:00, you get seen 3:15. You're waiting in an hour and a half in a room that people tend to not care about you much at all. They're more worried about photocopying your documents than you. And when the doctor does see you, it's 15 minutes, and it always ends in one of three things. It ends in either a test, a procedure, or prescription. Always. Why? Because that's how the doctor gets paid. The incentive right now is for the doctor to make sure you're sick. It is equivalent of back in the day, the old computer fixing model, the break fix model. They'd only fix your computer once they broke, and they'd hope your computers would break so they can keep charging you by the hour so they can fix your computers. So what did they do? They changed that model completely. Now, let me go instead now to the private model right now. If I'm wealthy and I just swipe my credit card or write a check, I go to a nice room that's really nice. My appointment's at 2:00. Maybe it gets in at 2:05 at best. That's it, right? Then when I sit there, the doctor talks to me. The doctor asks me, how are you eating? How are you sleeping? What's your stress level? I have a nice long conversation. Why? Because the doctor got paid already. Card got swiped, or I gave him a check. The doctor's fine. That's how the doctor gets paid. And wealthy people get that type of service. What I would like, instead of making a larger Medicare, Medicaid system, which is still the break fix model, I would like to expand the rich people model so the poorer people get a better model. There are several examples of this now. One of them is the company Forward.
So before we do the examples, I just want to be clear on this because you did say two things that I certainly agree with. That it's bad that we have a multi-tier health insurance system, and care system that the quality of care that that you get is different based on who you are. And that the profit incentives of doctors are often bad and don't lead to ideal care. All very true. But looking around the world, it seems to me that a really excellent way of dealing with both of these things would be for everybody to have one tier of care, because the state would be the single payer for medical costs, which is extremely popular everywhere that it's ever been implemented, and seems to certainly even in like Canada, it doesn't include dental and vision like it should, but the basic healthcare Medicare for all model is so popular that even Canadian conservatives have to pretend that they support it, or they're not going to win another election. Same thing with the NHS in Britain, and it seems very unrealistic to me that you're going to get a single tier of care for everybody. If bottom line, you still have doctors who are being paid either by insurance or by individuals. Either of those things seem like they would still lead to that. So how do we get around that?
Sure. Are you, and this is a question I have, are you advocating for this is the only system, meaning that private insurance would be illegal and or paying for a doctor out of pocket would be illegal. Are you advocating for that?
Yes, I am. So I'd also be curious about what you think about public option plans, but I think that you don't get, if you have just a public option alongside private options, you don't get most of the benefits of a completely public system. You certainly don't get.
I have an actual policy that will move us towards that. I do.
Okay, let's do it.
There are two pieces. I'll tell you my policy and why I don't like what you advocate for. My policy would be one that would move us towards this. This can't change overnight without violence or crazy upheaval. It would never get voted for. Everything is just, there's no way it would happen in my state. It's what either one of us is asking for is just not going to happen. It's without horrible disruption that will hurt just literally millions of people. I would like that to not be the case.
Okay, wait a second. So having Medicare for all that disrupted necessarily that would hurt millions of people?
Yes, because to make that happen, the powers that be right now, particularly in my state, but in most states, are much against it. So they're going to do everything they can to stop it. That's what I'm saying. That the people right now who are in power are not going to accept this, which means they're going to do everything they can to stop it. And they are literally going to go out of their way to crush people because they make billions of dollars on this. So it's not going to happen is what I'm telling you. Now, maybe there are states that could happen. Maybe it can happen in Vermont or something. In
New York right now, you have a majority in both the Assembly and the Senate co-sponsoring just that. It's been held back by the Democratic leadership, but that's a political struggle. That doesn't seem like it would be something that would have to, you'd have to spill rivers of blood or anything to win that
I'm
fight
sorry. Maybe my words were a little bit hyperbole. Maybe they were. I didn't mean that people would die, like you would be killing them. What I meant is if we try to fight on this to make this single payer piece happen in New York State, nothing will change. So the people now who are in trouble stay in trouble, right? The people now who don't have good health care keep that bad health care. That's what I meant. The wealthy are going to be fine. They're good. They'll leave the state. They'll do whatever. They'll fly to France, whatever. They'll do what they got to do. But the poor people now are the working poor and the middle class who don't actually, it's more the middle class and the working poor than the actual poor. The working poor and the middle class, they're struggling right now to have decent health care and decent health care insurance. If we fight on this, and maybe I'm wrong, but I'm telling you from my experience in my state, this is going nowhere for years. And it just goes nowhere for years because you said it, the Democratic leadership is stopping it. Yeah, because they're all in the pocket of these guys. So they're not going anywhere. So it's not going to go anywhere. So what I have now is a realistic situation to where nothing's going to happen. So people are going to struggle for years, maybe decades. I don't know how long, but surely for years. That's what I meant by having horrible outcomes. And there are 18 million New Yorkers. So there's a lot that makes millions of people who are going to be in trouble. What I'm saying is that's why I don't want to do that. I don't see that happening. So I think I have another answer, which I think is a better answer.
Let's do it.
And my answer is actuaries right now know about how much money you're going to spend on your either Medicare or Medicaid. They already know, right? They have your little box, whatever. You're a 40-something-year-old, male with a pre-existing condition, blah, blah. Odds are you're going to spend X dollars. And say for the example, sake of argument, it's $3,000. I'm making that number up just for argument. And they know that you're going to spend about $3,000. So what do? Literally, I give you a debit card with $3,000 on it. And I say, here's $1,000, Ben. Here's your money. You can spend it with any doctor you want. Just swipe the card and you can use it. Any doctor you want. Just go do it. But you only get $3,000 on this. After that, you got to go back to regular Medicaid or Medicare. So I'm not keeping you. You still have a safety net, but I'm giving you $3,000 up front. If you want to go to the cool doctors, you can. Any doctor you want, you could go. Or if you go too far, you go back to Medicare. Up to you. So you have a safety net. But I'm giving you the choice to make that happen. What do I believe will happen? I think most people will change nothing because most people don't. But there will be early adopters because there always are. Early adopters will go, you know what? Let me go to the cool doctors for a while. And they'll start going. They'll swipe the credit card. And when they swipe the debit card, they'll get the cool stuff that they like. They'll get better care. Doesn't matter whether they're poor or old or rich. Doesn't matter. If you're on Medicaid or Medicare, you get the cool doctor. When you like that, you'll want more of it. You'll think more about your health care. Number one. Number two, the people who now the doctors don't take insurance will go, wait a minute, I can get Medicare and Medicaid money without having all this admin? Yeah, no admin. Swipe a card, man. Don't gotta have forms, nothing. You don't have to have 14 people in your office fighting for getting your money out of Medicare, Medicare. None of that. Swipe the card. What I believe will happen is the pricing will begin to come down as they move towards those people to bring them in. I want the culture to move towards direct care. Why? Because in direct care, you are the customer, not the government. When the government is the customer, you are in the way. I don't want you in the way. I want you as the customer. Because I also want to encourage, along with that, I want to encourage companies like Forward. And if you happen to know what Forward is, but Forward is basically a subscription model, right? You pay $150 a month. It's heavily automated, but you get all the healthcare you want, period. No matter what. No copay, nothing. $150 a month. Now, not everyone can afford $150 a month. I get that. But whatever you could create to begin to make that happen. If I've got my debit card, yeah, I can. I could use my debit card to join one of these. This is like the gym model. They're all about prevention. You agree to join Forward. Literally, they check you every month. They don't want you to come in. They want you to be healthy because they get the $150 no matter what. So it would also encourage that. Now you might say, well, Larry, there are some people who couldn't even afford that. You're right. Now, if you're at a point where you have no address, if that's where you are, you go to emergency room anyway. I mean, I get it. You're going to go there anyway. I got it. That maybe we need to have some kind of negative income tax to help them out, or UBI style, maybe for that. But that's done. But for the average working poor or middle class person, they can afford the $150, and if they're Medicare, Medicare, they can swipe. If not, they can afford $150, far less than they're paying now. But even better, now once you have enough of companies doing that, you can now incentivize those companies. The government can say something like, as an example, you can say, hey, I tell you what, if you'll take 10% of your population as poor, as we, the government, decide poor, however the government decides that, maybe it's families who are available for school lunch. I'm making that up for sake of argument. Then we will say that you have to pay no state payroll tax while you do that. Now, for a smaller organization, not that big of a deal. But for large organizations, that's a big deal. They'll take in anyone, which means now any working poor person and any middle class person can get the same quality of Medicare as of medical help that anybody else could. That doesn't take 5 minutes. That's a multi-year plan. I get that. But it's a long-term plan to change how we think about healthcare. That's what I want to do.
So the $3,000 healthcare equivalent to the bridge card, would that, so just to be clear, that's not means tested. That's for everybody.
No. That is for someone who's on Medicare or Medicaid now. Okay. That's what it's for. For someone who is right now on Medicare or Medicare right now, right? They would get their card up front. If they run out, they still can go back to Medicare, Medicare, right? But they just don't get the special cool card.
That answers my question. So
yes.
So if that's the case, then it seems to me that if you want to give people concretely, if this were up for a vote or something, do you give people $3,000? Sure, but if we're thinking about solutions and what that looks like and whether that really gets to the nub of the problem with the American healthcare system, then I think when we look at actual bridge cards and how that's played out politically, when you have a benefit that is only for people who meet certain kinds of means testing requirements. In this case, it would just be whatever it already is for Medicaid. Yep. Then what that does in practice, I think, is it makes it extremely politically vulnerable because most people don't think they'll ever need means tested benefits, even if they really will. They don't think they will, and so it's easier to cut it than it is something that's a universal program for everybody that everybody is.
I don't understand what that means. What do you mean? You mean the government will cut
easier, politically easier to cut because if you
politically easier.
If you have something that's a universal program like Medicare in Canada or the NHS in Great Britain, that's something that everybody except maybe people who are so rich that they'd actually be net better off without it. But they have but everybody more or less understands that it benefits them and feel very defensive about that. That's again why Tories, can't have to at least pretend that they basically like the idea of the NHS when they run for office, even if they undermine it in small ways. Whereas, with means tested benefits, you can just do like, Bill Clinton in the 90s and run on, I'm going to end welfare as we know it. And people cheer because they think that, oh, that's for these moochers who aren't like me. I'm never going to need this. So that's one problem I see with it. The other problem is that I think the nature of health insurance, of health costs, is that they are extremely unpredictable. That you don't know from month to month necessarily, what's going to happen. And of course, like every other commodity, if it continues to be treated as a commodity, prices don't just stay static, right? I mean, especially if you're pumping,
they go down.
Well, I think that's a open empirical question. I mean, if you gave a lot more people a lot more money.
No. I'll give you an example of it. Okay. There is a medical field that's right next to the medical field, which is the non-essential, right? The non-essential fields in medicine. LASIK eye surgery, cosmetic dentistry, body enhancements, things like that. It's right next to it. I mean, they're right next to each other, right? And in every case, price has gone down, technology has gone up, accessibility has gone up, improved every single time. When I was a kid, LASIK eye surgery, you used to do it per eye because it was too expensive to do 2 eyes. That's how expensive it was when I was a kid. Now, anybody gets it. Cosmetic dentistry used to only be for like stars or something, right? Used to be this for only like superstars. Now lots of people get cosmetic dentistry, right? I think when you take it out of the government, in that case, in every way, it's gotten better.
Okay,
more accessibility, not perfect, but more accessibility.
Because you're like, certainly it's true that there are things that have gone down in price over time from when it's new technology to et cetera. That's absolutely true.
Sure.
But it is also true that that many healthcare costs go up over time. And if you want to say, oh, okay, well, that's all because of government involvement, and if we just and if we have less government involvement, that
no, it's insurance company involvement. It's government and insurance company involvement. Both of those two. It is both government and insurance company involvement. Both of those combined. It isn't just government's fault. It's also insurance company's fault.
Okay. Well, I appreciate that, but I mean, but it's also the case that if we look at countries like Canada or the UK and compare to the United States in terms of cost, the overall amount of money spent by everybody on healthcare is lower in those places than it is in the U.S., despite the fact that the government role is much larger. In fact, the government role is the role. It's the single payer of doctors in this system, and people would seem to get better care. Certainly, if you look at comparative life expectancy, and you can try to blame that on lifestyle factors. I think I grew up close enough to the Canadian border, spent enough time there. I'm pretty skeptical about the lifestyle explanations, but you have seem like a lot of Canadians drink a lot of beer and eat a lot of Tim Hortons, but then you can
they do.
And then, but even if you buy that, I mean, you can look at the differences in infant mortality. I think the infant lifestyles are pretty similar, and certainly you can look at the overall figure of mortality amenable to healthcare. How many people per thousand or per million are dying from things that timely health interventions could have prevented, and that's also. And those figures are also better in those systems. So I guess what I'm really curious about, and maybe this takes us back to the larger point you made earlier about Davids and Goliaths, is you've been kind of framing your opposition to Medicare for all or the state level equivalent, which would really be a public option because you can't really do Medicare for all in a single state. You've been framing that in terms of political viability. We're just not going to get this soon. But I do want to press on this a little bit.
Second piece. that one, and I also want to change how we look at healthcare. So there were two parts of that. But please keep going.
Okay, so but if the political struggle was won at some point, and you were convinced that this actually is now a politically viable thing, that this could happen, or could happen in the short term, would you then say, oh great, we can have Medicare for all, or would you say nope, too Goliathy, taxes, force, I don't like that?
There are two parts to this. The one thing I don't like with the Goliathy piece is that there's no other option. In Europe, there actually is. In almost every European country, the wealthy people have supplemental insurance, which is another form of insurance they get, not even often in their country, sometimes outside their country, sometimes in their country, but they get another form of insurance. They insure themselves some other way, so they can go to other countries and get stuff. Medical tourism is a thing for the wealthy. So the wealthy actually get a second tier anyway, even in European countries that have that. They already do get that.
In some cases, it's medical tourism to countries that have national health care, like Rand Paul famously going to get you fixed up in Canada.
Sometimes, but there's also ones like Vietnam, right? It's also places like that too, where what they basically have is it's a privatized hospital. All the people, because of our terrible immigration policies, we train doctors and send them back to their country when they want to stay here. So because of our bad immigration policies, we actually have assisted with medical tourism. So I think, there's that issue. So I wouldn't want it to be where there's no other option. If I believed, and I'm not sure I do believe this, but if I did believe that in reality, a single payer system would actually provide better service to everybody, I would still want the option of having privatized insurance if you wanted it. For example, unions might want it, individuals might want it, entrepreneurs might want it, doctors might not want to work for that. So I'd still want to have it there. And what I believe is if that's the best way, then people wouldn't go to the private insurance that much. It would be a small part of our it'd be a niche within our country. And if that's the answer, I'm okay with that. I'm not okay with the idea of saying, no, the government decides. And here's the reason why. Never have I seen, and I could be wrong, and I'm open to being wrong here. Your chat, by the way, is really a bunch of assholes, but that's okay. I expected as much.
I think it's a matter of, I think some of that's a matter of perspective. I expected
that, but it's fine.
I would also say that when I go on libertarian shows, I don't read the chat, and there's a reason. But yes,
no, but my people are good. They will never be mad at you. My people are good. My people are good
in the future.
No. Yes. My people are good. Okay. But in any case, I've never known of a monopoly that really services its people very well. It just isn't that common. Can this be the exception? Maybe, but it's hard for me to see it as the exception when, again, the medical field next to the medical field, which is the non-essential, everything's gotten better. When it comes to the essential, everything's gotten worse. When you add the insurance company and you add the government together, you've got two Goliaths, right? The private Goliath and a public Goliath together. And I feel like things are just don't work. That's what I would say. And I think monopolies tend to not be the right answer. And most people would say monopolies are bad. I would agree.
Yeah, well, I think the private monopolies are bad. I think public monopolies can be very good. Without the problem with private monopolies is having the lack of either form of control that ordinary people might otherwise have. Either the limited form of control that you can have in the private case through freedom of exit, or the I think much richer form of control you can have through all the Davids collectively owning something and getting democratic input on it. However,
wait. So are you saying that you would want this to be a cooperative?
So I think that all I'm saying is if the state owns something and the state is democratic, then there is some way in which the public has influence over this thing, however indirect, however imperfect. Whereas if it's a private monopoly, it's a completely different situation because the CEO of the company is neither up for election nor is an appointee of somebody who is up for election. But I'd also say that in
our current system, that's not true.
In this particular case, in this particular case, I think there's evidence that public monopolies lead to better outcome. And in terms of the point about options, sure, I want people to have options, but I would ask, what are the options that are most relevant to meaningful freedom in practice? And I'd say that right now, most people are not particularly emotionally invested in whether the parasitical middleman between them and their doctor is Blue Cross Blue Shield or Aetna. I don't think most people care about that. In fact, most people, when they're trying to pick between health insurance plans, are hopelessly confused and have trouble seeing the difference. Even professional economists, in some cases, trying to choose healthcare plans, report having those feelings. But the kinds of decisions that people do care about are things like, do I have to stay in this job I hate? Because if I quit, I would lose my health insurance, and I don't know how quickly I can
agree
find
completely.
a job. Those things seem to be much more important freedom issues than whether you get to decide who your health insurance provider is.